I'm James Lindsay, and I'm sitting here with Peter Irving, and we're going to present this deep dive into Best of DDW 2021. And this program would not be possible without unrestricted educational grants from our sponsors, AbbVie, Amgen, Bristol Myers Squibb, Celltrion, Galapagos, Janssen, Pfizer, Takeda, and Tillard's. And just to stress again, they generously provide funding, but have no influence on the content of the program. I'm not going to spend long on how the program's developed because I know a lot of people have already dialed into one of these before, but it's a group of people who sift through the abstracts in IBD presented at DDW, select in advance those that are most likely to be impactful, run through as a group of faculty and fellows the abstracts that have been presented, and then create the slide deck that we're going to show you a very small subset of. The course is directed by Marla Dubinsky and David Rubin in the US. It has a faculty made up of IBD experts from the US, Australasia, and the UK. And importantly, all the work is done by the fellows. They go and listen to the presentations, obviously all online this year, and a particular shout out to Hannah and Susanna, who were the UK fellows as part of this program. And obviously, normally we select about 30 or 40 abstracts across a range of different areas and present them very briefly. But we've decided, because we had an opportunity to do a third webinar, of trying to do a bit more of a deep dive into some of the most impactful abstracts and some of the most interesting. And you can see here the topics we've chosen: a little bit about diet, about JAK inhibitors, S1P modulators, the head-to-head trial in Crohn's disease, stopping, sequencing, novel, and combination biologics. And we're going to run through some of the abstracts dealing with those topics over the course of the next hour and a half, starting with diet. And effectively, I'm going to focus a little bit on the role of food additives or ultra-processed foods in terms of the risk of developing inflammatory bowel disease. And the reason for that is there were three key abstracts presented at DDW, and I'm going to run through them in time. So importantly, processed food, that's food that's altered during preparation and can include the addition of preservatives, but ultra-processed food are foods that are packaged and formulated containing additives, artificial flavoring, thickeners, and coloring. And they can include those additives that are thicken, which is CMC, carboxymethylcellulose, polysorbate 18, and carrageenan. They're what give foods their mouthfeel. The first on the left is the PURE study. For those of you that are very up to date, this was published last week in the BMJ as an article. And it's effectively an epidemiological study. It's using the PURE cohort, which is a large number, nearly 120,000 people, aged between 35 and 70 across 21 countries in North America, Europe, South America, and Asia. And these patients completed a food frequency questionnaire that was country specific at baseline. And then they were followed up over a median of 9.7 years with a primary outcome of the development of inflammatory bowel disease. And as with many of these studies, they excluded diagnoses that were made within the first year in case changes of diet were effectively a response to incipient disease rather than an association with its development. And as you can see here, they diagnosed 467 incident cases with a significant predominance of ulcerative colitis versus Crohn's disease, 377 UC versus 90 patients with Crohn's disease. And you can see here in the graphic, effectively, the impact of ultra-processed foods and the hazard ratios of developing, on the left-hand graph, inflammatory bowel disease, in the middle, Crohn's disease, and on the right-hand side, ulcerative colitis. And what you actually see in summary is that compared to the standard, which was less than 1 serving a day of ultra-processed food, as you increase the number of ultra-processed foods that you ate per day, you increased the risk of developing inflammatory bowel disease. And overall, the highest, greater than 5 servings a day, was associated with an almost twofold risk of developing inflammatory bowel disease. And the sort of foods that were included were soft drinks, refined sweetened foods, salty snacks, and processed meats. As you might expect, there was more intake of these across North America and Europe and South America than there was in Asia. And that's the first study.
Can I ask you a couple of things about that then?
Okay.
You know, the big problems here is about confounding. Well, there's many problems, but confounding is a really big issue, isn't it? And, you know, an unhealthy diet, if that's what we're going to call it, is probably associated with a whole lot of other behaviors as well, isn't it? And, you know, whenever you see abstracts at DDW, you see abstracts about, I don't know, exercise, sleep, you know, in the past, smoking.
Yeah, so I think that's a really good point. So obviously, these are done with adjusted multivariate regression analyses to try and take into account those confounders. But for example, and I think you raise a really important one, as one might expect, if you looked at the incidence of disease across the population, you found a higher incidence of Crohn's disease in this population in people who lived in North America, for example, and Europe than you did, for example, in Asia. Now, that's what we know, because that's what we know about the incidence of disease. But of course, also the intake of ultra-processed food is higher in those places. Is that a confounder? Now, they took country into the regression and the adjusting analysis, as they did smoking, as they did education level, as they did sex and other factors. But whether you have completely excluded all those confounders, of course you don't know. And I guess that raises an important question, which we may as well address now before we go into the next study, which is when you look at these kind of, you know, eating this is associated with a higher risk of inflammatory bowel disease. One of the questions you then have to decide as to whether it's just an association or a causative thing is it a plausible biological hypothesis?
Right.
Is it logical that eating ultra-processed foods might impact the incidence of inflammatory bowel disease? And of course, there is really lovely scientific data supporting the concept. And that comes from Benoit Chassaigne in his really lovely paper in Nature, where he showed in mouse model, murine models of colitis, that supplementing the diet with CMC, carrageenan, or polysorbate 80 led to a dramatic shift in the microbiome. And that shift in the microbiome was associated with a reduction in the thickness of the mucus layer and increased encroachment of bacteria into the lamina propria, and a higher risk of disease and a higher severity of disease in IL-10 knockout mice. Interestingly, he also showed that altered microbiota, so effectively the ultra-processed food-associated microbiota, was in its own right calitogenic. So it wasn't the fact that the emulsifiers effectively emulsified the mucus and allowed the bacteria to get into it. It was the alteration of the microbiome that was really important. So there is a plausible hypothesis. I'm going to move on to the second study. It's much the same, just a slightly different design. It's using a combination of some of the really large epidemiological databases. That's Nurses Health and Nurses Health 2, which is predominantly women in the US, health professionals, which includes men, and looking at 250,000 patients with just 5.5 million years of follow-up. So truly huge study. The median age, though, at diagnosis of inflammatory bowel disease in this cohort was 56, and we'll come on to that in a moment. This study showed more equivalence between the ratio of UC and Crohn's disease diagnosed. But again, you can see here in the top, ultra-processed foods being associated with a slightly lower, a 1.1 1.2 increased risk factor of developing Crohn's disease. And interesting in this study, no association with ulcerative colitis. And of course, one of the criticisms of both of these studies is they only include people in their later years of life. So this is all about older onset inflammatory bowel disease. It doesn't say whether the majority of our patients who are diagnosed before the age of 25, this is a relevant factor.
Are there cohorts out there, pediatric cohorts that look at this?
Well, there are pediatric epidemiological cohorts, the EpiMed cohort, for example, in northern France, but they haven't looked at dietary intake. But the one study that has tried to address that in a slightly not quite large enough is the Enigma study from Australia and Hong Kong, and that's a case control observational study, small number of patients, 195 patients with Crohn's disease, and then their first degree relatives, and then non-related healthy controls, looking at early life processed food and usual current food additive intake. And what they show is that patients with Crohn's disease currently are more likely to eat processed meat and other ultra-processed foods than their household controls, but also they are more likely to have eaten it in their past than their household control. So perhaps showing the same thing is relevant in a younger population.
Cause and effect, is this the fact that people with subclinical Crohn's disease avoid certain foods?
Yeah, I mean, of course, yes, that might be the case. Although the median time to diagnosis in the North American study was 5 years. So that's quite incipient Crohn's disease starting 5 years ago. And I think actually, while we're on it, I guess one of the biggest criticisms of this kind of study is, can you really use a food frequency questionnaire to assess the intake of ultra processed foods? And the reason I say that is because obviously a food frequency questionnaire asks you the frequency by which you consume certain types of food, and obviously it can't go down to absolute minuscule details, but it will include things like fizzy drinks. It will include things like salty snacks and processed meat. And to some extent, you might think that would be enough, because presumably all of those things contain ultra-processed food. But they don't really. I mean, if you think of fizzy drinks, for example, there's sparkling water. It has no additives in it at all. And then there's iron brew. Who knows what's in it? And the same with things like salad dressings. There are salad dressings that have huge quantities of polysorbate 18 and carrageenan in them, and then there are salad dressings that are completely food additive free, and the food frequency questionnaire thing will be salad dressing. So
so you need a proper food diary.
Absolutely, you need a proper food diary going down as far as the brand. Yeah. Because it's really, having done a little bit of work in food and emulsifiers, it's down to the brand. Different brands are very different. So moving on, the next is just included, because it is in diet, we're talking about diet, and it's a really lovely designed dietary trial. It's comparing the specific carbohydrate diet, which is high in unprocessed meats, eggs, vegetables, fruit and nuts, and low in sweeteners other than honey and dairy, compared to the Mediterranean diet, which is that high olive oil, high fruits and vegetables, low red meat and sweet food. So these two diets compared in a group of 190 patients with Crohn's disease, randomized to one diet or the other. And the strength of this trial is it's what's called a prepared food trial. So patients weren't given dietary advice. They were literally given every single meal that they ate over a 6-week period that were prepared in a controlled academic diet kitchen. And so you were absolutely clear that those on the specific carbohydrate diet were taking that, and those on the Mediterranean diet were taking that. So to some extent, this is the most robust of the dietary trial designs, perhaps less related to real world. To some extent, I think the criticism of this is the inclusion criteria. It included people with moderately active symptoms based on the simplified Crohn's disease activity index, but it allowed people either with or without an objective marker of inflammation, such that only about 50% of patients had either an elevated fecal calprotectin or an elevated CRP. And therefore, to some extent, you've got a very heterogeneous population going in, and you're not really sure, is the diet treating the functional symptoms of someone with quiescent disease, or are they treating the inflammatory symptoms of someone with active disease? So you don't really know that. But having said that, symptomatic remission, clinical remission, and a reduction in fecal calprotectin was observed in those that had an elevated calprotectin at baseline, but you can see no difference between these two diets. I think it's a missed opportunity because I think it hasn't really answered a question that is useful.
But there's another missed opportunity here, isn't there? And that is, where's the usual diet group?
Absolutely. So this is not a placebo or sham diet control group. It's an active comparator group. And of course, to some extent, if the idea is that you're powering this for superiority, you have to assume one diet's better than the other. If you're powering it for equivalence, 191 patients isn't nearly enough. So it's an underpowered trial in a mixed population.
So I'm going to ask you a question here. Let's see if people are asking questions as well. But I'm going to ask you a question, just like a really clinical thing here. Do you think the specific carbohydrate diet works?
I have absolutely no evidence that it works.
I didn't ask you that. I said, do you think the specific carbohydrate diet works?
Honestly, I don't think it does. In terms of treating active inflammation, I think the trouble with dietary trials is you really need to know what your hypothesis is before you start the trial. Because if you're trying to treat functional symptoms, and obviously modifying the diet changes symptoms, you need to make sure you've got a group of people with quiescent disease, and you need to make sure you've got a really good quality sham diet. If, on the other hand, you're trying to treat active disease, you need to make sure that you're measuring objective markers of active disease, because we know that modifying the diet modifies symptoms. So for a specific carbohydrate diet, I don't know why it should work.
Okay, so let's put it another way. We know that enteral nutrition works in Crohn's disease, right? There's no question about that. Everyone agrees.
Certainly in children and probably in adults.
Yes. Okay. So there are other diets out there. There's the Crohn's disease exclusion diet, there's CD treat, and there's certainly strong suggestions that they work as well. Yeah, and
absolutely.
I think part of the problem is we don't really know why any of these things are working.
Well, okay, that is a good question. So we don't really know why enteral nutrition works, and we don't really know why the CD treat diet works. And the CD treat diet is effectively a non-formula diet that is supposed to mirror the microbial and biochemical impact of the enteral nutrition. And we don't know why they work. I think a bigger question is why is it that we don't have good quality dietary trials? And I think there are several reasons. Of course, funding might be one. Pharma funds good quality research trials. I think the other issue is the difficulty of designing a good quality diet trial, because of the difficulty of having appropriate blinding, so and appropriate controls. As you said, this doesn't have a control. A good control for this would be a sham diet, a diet that changes as many things as the intervention diet, but has no impact whatsoever on nutritional intake or the dietary change of interest.
Difficult with two interventions.
Absolutely.
In fact, impossible.
Impossible with two interventions.
But still, right. Some things. So first of all, so Charlie shares our thoughts. I think Charlie Lees shares our thoughts about the sort of the problems with the pure study, but agrees it's important. What else have we got here?
What is the Mediterranean diet? Well, it's a diet high in rich in olive oil, in red fruits and vegetables, tomatoes, peppers, white meat and fish, low in red meat, low in processed food.
It's a nice diet.
It's the Southern European diet, the Mediterranean diet.
If I had to follow a diet for Crohn's disease,
red wine, it's got red wine in it, yeah. And Stuart asks a really good question, Stuart Bloom, that I'm afraid I'm going to have to be ashamed to say I don't know the answer to. How do these two diets compare in the content of saturated fats? I would think they're both low in saturated fats. I couldn't tell you in terms of MUFAs and PUFAs, but they both are effectively low in saturated fats, but I couldn't tell you the exact details.
Is that true for the SCD? I seem to remember the odd patient I've got. By the way, I think the SCD diet might work actually.
Okay, we'll do a trial.
No, I can't be asked to do that. too many other things to do in life.
I think we should move on because we've got lots of time.
Right.
Well, probably not much time, and lots of interesting slides to go through. So moving on, Pete.
So we're on to JAKs next, and we're going to start with a little bit of real world data from tofacitinib, just as much as to frame the discussion around JAKs rather than anything else. There's a couple of retrospective observational studies presented. Sorry, one's prospective actually. So there's David Rubin's data from Chicago, and perhaps not surprisingly, the one below the Belgian data is from Leuven. And there are lots of cohorts out there, including UK cohorts as well. I think the things to take away from these cohorts are things that we probably know already, and that is that the large majority of patients that we've treated with tofacitinib over the last 3 or so years have been TNF experienced. Many of them have been multiple TNF experienced. Many of them have also been exposed to vedolizumab as well. So there is sort of a multiple biologic cohort, a multiple biologic failure cohort. And I think, therefore, that when you start to look at, particularly at the Belgian cohort, where you see that that a third of the patients hit clinical remission by, I think it's up to 26 weeks was the definition here, you see that's actually probably quite impressive. If you also look at the endoscopic data, real world endoscopic data, accepting there's low numbers, certainly in the Chicago cohort, you're seeing between something like a quarter and maybe as high as 2/3 patients going into endoscopic remission. Of course, highlighted beautifully here with the Chicago cohort is the fact that most of them don't get scoped. Although, in fact, I can tell you that that we followed our early cohort very closely indeed and scoped them all at 14 weeks. And if you used a sort of Mayo 0 or Mayo 1 as your definition of endoscopic remission, then about 50% of our patients were hitting that by about 14 weeks. And then again, histological remission, whatever that means and wherever it leads us, is certainly seen in a significant cohort of patients. I think, interestingly, if you look at the Belgian cohort, 30% of these patients are hitting colectomy at some point.
They're a sick group of patients. If 30% are having a colectomy.
And I think that's true. And the real question is, maybe this is the time to talk about that. This is you know, what is the tofacitinib cohort now? Because you know, we've seen some safety data from the oral surveillance study, which, if I describe it in 30 seconds, is the rheumatoid cohort of patients over 50 with a risk factor for adverse cardiac events, who were randomized either to anti-TNF or to either 10 milligrams or 5 milligrams of tofacitinib, and they had rheumatoid arthritis, and adverse outcomes were seen at higher rates in the 10BD group, which isn't licensed in rheumatoid.
Cardiac, thromboembolic, and malignant, non-melanoma skin cancer,
and death in the over 65s.
But you see, I find this difficult, and of course, I think the use of tofacitinib has now polarized and is different in North America than it is in Europe.
Agreed.
I think that in North America, tofacitinib is considered a drug of last resort. Whereas I do not think it as that in my practice at all. I think it is a drug that is absolutely ideal for young people, as long as they're not women who want to get pregnant. I think if you look at all the side effect data, the people who develop side effects are quite predictable to some extent. They're older, they're more comorbid, they may have been on steroids. They are the people on the 10 milligram per kilo, 10 milligram twice daily dose, definitely. But a lot of my patients aren't that. And so I think you've got these two practices. In the US, tofa, last drug. In certainly my practice, I do sometimes use tofa before an anti-TNF, because there are patients for whom a tablet is more suitable than an infusion. And the one thing we know about tofa, it works quite quickly.
Absolutely. I think, you know, there are many other things about it. I think, you know, if you look at clinical experience and if you look at the sort of network meta-analyses and things, in the post-anti-TNF position, my God, it's a good drug, isn't it?
Yeah.
No question about that. We mustn't throw the baby out with the bathwater.
I completely agree, and it's really interesting sitting on advisory boards and you see these two different opinions.
Yeah.
I mean, active ulcerative colitis is a disease that is associated with morbidity.
And when you look at those groups that aren't in the high risk situation, if you like, we need to see those absolute risks. And we need to remember what the absolute risks of active disease are. Absolutely. And let's not forget that the other drugs have side effects as well. So,
and when you get to those risks that people are concerned about, like thromboembolic events, and you drill down into the absolute patients, the 4 patients, I think, within the active treatment arm in the TOFA experience, they all had risk factors. So if you're careful about screening, I think you can mitigate that risk to some extent.
There's one patient in the TOFA clinical trial program now, beyond Octave, that has had a VTE who didn't officially fit the risk. They almost did by age, I think. But
so we're going to move on, and I guess that's the real. This is now the real critical question: is TOFA is a moderately pan JAK inhibitor with impact on JAKs 1, 2, and 3, and what do you get more bang for your buck with better safety if you lose a more selective JAK inhibitor?
Right, and I think that's one thing to remember about JAKs is probably the higher you push the dose, the less selective they become.
Yeah, absolutely. But of course, the higher you push the dose, and I think this is really true, the higher you push the dose, the better the efficacy.
Undoubtedly.
But with tofacitinib, the higher the risk.
Right.
Is that the same for the more selective?
Well, I think it probably is, actually. Let's look at the filgotinib data which is presented here. Maybe we can just briefly talk about upadacitinib, which wasn't the data weren't presented at UEG. We just had DDW, but were presented at ECHO. So this is the selection study. So this is basically the 2B3 phase 3 studies for filgotinib. And these data were presented at DDW. It's a slightly different program to ones that we've seen before, because in fact what they didn't do is change between the doses. They carried on at their 2 specific doses of 200 and 100 versus placebo. But it is fairly typical in that, again, it's a randomized responder study. So if you look at the 2 graphs on the top right-hand side there, you've got the 2 induction studies on the left, the biologic naive patients who, not surprisingly, did better than the patients on the right, who are the biologic experienced patients. You can also notice from these 2 studies that in neither of these studies did the 100 dose hit its endpoint.
Yeah, I don't suppose we'll be seeing 100 in induction.
No, agreed. Go down to maintenance, and actually you do see a difference there between 100 and placebo, as well as between 200 and placebo. But in each of those graphs, you see, perhaps least convincingly, I guess, in the biologic experience induction study, but you see a dose response there, don't you?
Yeah, and I mean, if you look at the difference in deltas, 10% with 100 in maintenance, 26% in 200. I don't actually know what dose they're going to put on their license, but I know what dose I'll be using, and that's 200.
For induction.
And for maintenance.
Right, so here's a question. Maybe we need to wait for the study, but if you believe that side effects of JAK inhibitors are dose related, which of course you do, I know you do, you must do.
Yeah, I do.
Okay. What about 200 induction and 100 maintenance with the ability to go back up to 200 maintenance?
So that all depends on a piece of data that we don't know, which is, do you do better if you drive down the inflammatory burden early? Or do you lose a trick by dropping the dose down at week 10 at the end of the induction study and allow effectively the inflammation to reoccur and then have to go back up again? Are you disadvantaging your patients? And of course, the answer is we don't know, because this study didn't include a dose escalation option.
I think Galapagos are going to do that, though.
We'll see. We'll see. We do have some questions. Okay, this is Charlie saying, very keen to know what you both think about the recent Dear Doctor letter on the restrictions on TOFA prescribing. Will this change the patients you're currently treating? Well, to some extent, not, because I'm already treating a group of patients that wouldn't fit within that. I mean, you know, explore other alternatives in advance.
Depends. You know, and Charlie, I'm sure you think the same. You've got to weigh up what those alternatives are and how effective they're going to be against the risk of causing serious damage to a patient. You know, so if they're a low risk patient you're thinking of giving tofacitinib to, and you think that is going to be the best drug, then I'll probably still go for it.
I mean, I think what we really need, and I think this is something that will come, is a prediction tool of the risk of side effects, or more importantly, the absence of risk of side effects. I can imagine that you'll be able to develop a clinical prediction tool that might include age, comorbidity, some other background factors.
I think we've got that prediction tool.
Yeah, but we don't have it in a way that is a Palin chart that we can say.
Yeah, but I mean, how accurate? What, to my mind, Octave is that prediction tool. You've got a whole load of patients in there who don't have these risk factors, and they don't tend to get the side effects. I know that's not what you mean, but that's the reality, and that's what we've got to use at the moment. So, you know, I know where you're coming from, and I agree, and that would be fabulous, but we're not going to get that for a while.
And then there's a great question here, Reza Saidi. Would you give a DOAC or Clexane to a patient in whom you're treating with 10 milligram TOFA? It's a really great question. Would you do that?
So just for everyone, no, I wouldn't. Not at the moment. I think I would need a coagulation expert to persuade me that that was the right thing to do, or in fact to inform me that that was the right thing to do. I think the one thing that's clear is that the biggest risk factor for venous thromboembolism in patients with inflammatory bowel disease is active inflammatory bowel disease. And in fact,
it's shown in this slide, actually, isn't it? It's shown in this slide.
Right. If you treat the disease, you decrease the risk of venous thromboembolism. And if you're using an effective drug, then, you know, that's the best way to do it. Have I ever given a DOAC to a patient who I've treated with tofacitinib? Yes, but that's because they've had a venous thromboembolic event in the past.
Yeah, and I'm cautious about giving the drug in that circumstance.
Well, I absolutely.
Which you are too, but you probably have no alternative.
Right,
yeah.
But no alternative. So.
And I think from the safety data, anything new here, Pete?
Well, not really. I think, you know, can you actually say anything about the risk of venous thromboembolic events with filgotinib in this trial? Not really. I mean, if it had come out as being clearly positive, then you could have said that. But can you say the risk is not there? No, you can't. You know, if you were to use tofacitinib as a parallel to this, then of course, if you didn't have the oral surveillance study, you would have said there's no risk.
Yeah, of course, and we haven't got that kind of data.
No. So there will be a lot of sub-analysis going on of the rheumatoid cohorts. And the UC cohorts and Crohn's as it comes to Filgo and UPA, to try to tease out those high-risk patients to see if there's anything. I don't think they'll show anything because I don't think they're going to be big enough to show anything.
And that, of course, takes us to the upadacitinib data. Now, that wasn't presented, and we don't have a slide on it because it was presented at ECHO. But I mean, I think there's a really interesting thing. I mean, the upadacitinib data induction studies, two absolutely equivalent studies comparing 45 milligrams of upadacitinib to placebo in patients with standard active ulcerative colitis, showed really strikingly high induction benefit, perhaps the highest benefit that we've seen in a trial of ulcerative colitis so far. Interestingly, if you compare the anti-TNF naive to the anti-TNF exposed, the absolute rates are lower in the anti-TNF exposed, but the deltas are quite preserved. And I think one of the striking things I think about UPA is because of its phase 2b, it has effectively, it's maxed out on its dose efficacy, because we really saw that increasing up to the 45 milligram, which I'm not sure all the others have. So I think what would be really interesting with upadacitinib in the maintenance data, which isn't yet published, is to look at the side effect profile. So having increased the dose to a dose that gives you really impressive outcomes, are you suffering in terms of safety?
I mean, we've effectively maxed out on TOFA, but not because of efficacy.
Because of safety.
Right. And filgotinib?
We don't know.
We don't know.
Because they've never gone high enough.
James, I'm going to move you on to S1P.
Okay.
I think that's next.
It is, I think. Oh, let's try and see. Yeah, so S1P, it's a new drug type. It's going to be hitting the clinic soon. It's one we're not familiar with because we don't have a drug in class yet. The theory of S1P is that sphingosine 1-phosphate, which has multiple isoforms, 1 to 5, is expressed as a gradient on the in the mesenteric and other lymph nodes, and leukocytes that are within there migrate out, they egress out along a gradient. And so an S1P modulator, among other aspects of its activity, traps newly differentiated effector lymphocytes in the mesenteric lymph nodes. And that's effectively how it works. And ozanimod is the first in class to come out. It's an S1P1 and 5 modulator, and it's got really nice data for its induction study. This is at week 10. Again, clinical remission, delta of 12%. I guess that's equivalent to the lower dose Filgo 100 if you can compare across studies. But again, clear signal of benefit across the range. And then it's a fast-acting drug, and you can see here, this is the speed of change of the patient-reported outcomes, stool frequency in the top graph, rectal bleeding in the bottom graph, and you can see clear blue water between placebo in grey and drug in blue, certainly for rectal bleeding at week 2. Perhaps it takes to week 4 for stool frequency, and you get nice reductions in objective markers of inflammation. This is calprotectin and this is CRP. And so I think we can all conclude that ozanimod works. The magnitude of its efficacy is certainly equivalent to the majority of advanced therapies that we've seen. Of course, you can't compare across trials. I might say that upadacitinib, the data looks a little stronger, but you can't compare. And then in the maintenance arm, this was a true randomized responder. And of course, we've only got the 1 dose of ozanimod, but a true randomized responder. And again, you see a really nice, clear benefit across all endpoints. And I think when a trial meets its primary and then all secondary endpoints, you sort of know the drug works.
Right.
You know, it's not a statistical blip. Yeah. You know, this, whatever the endpoint you look at, be it symptomase based, endoscopic based, steroid-free remission based, have an impact on histological healing, you can see that the drug works. I guess where it fits in will depend on a couple of things. It will obviously depend on cost. I think the cost of the drug will have a major impact how it's used in many jurisdictions, but also, of course, on safety. Now, I think it's fair to say ozanimod is a relatively safe drug. It's just got a couple of quirks, and the question is, will those quirks make people lose confidence in using it? One quirk is that it does have a marked impact on the peripheral blood lymphocyte count. So patients on ozanimod develop a lymphopenia. Now, theoretically, the reason they develop a lymphopenia is because the lymphocytes are trapped in the mesenteric nodes. They're not circulating. What we don't know is whether that lymphopenia translates into an increased risk of infections. Yes, you get infections. Clearly, you get a few more infections, actually no higher than in the placebo rate. But of course, we know that from large studies in azathioprine, but across all indications, that the degree of lymphopenia is normally associated with the risk of opportunistic and serious infections. But of course, this lymphopenia is slightly different. This is not apoptosis of lymphocytes. This is trapping of lymphocytes. And whether that lymphopenia is risky or not, we don't know. It causes a little bit of a raised ALT, but the two things that I think might have an issue, one is it causes a slight reduction in heart rate. But I mean, being honest, it's about 1 beat per minute. And the other, it has been associated with macular edema. And the issue with that is in its label, patients will have to have an ECG, and patients with a history of diabetes, uveitis or macular edema will need to have appropriate fundoscopy by an expert. And I guess that might be the issue in people's clinical practice. I'd be interested to know if people are listening in on the chat, do people feel that the beat-to-beat variation of 1 or 2 beats per minute and the need to get an ophthalmic assessment in people with diabetes will be a limiting factor for this drug? Because actually, apart from that, it's a relatively well-tolerated preparation.
Yeah, we had a few whose LFTs went off, but that wasn't actually much of a problem. And I think actually it says the relevant thing about heart rate actually is is mentioned on this slide here, that it may slow heart rate or AV conduction. So it's not actually that you get a decrease in number of beats per minute that matters. It's that people who have got conduction defects, you don't want to treat with the drug.
So you don't want people with heart block.
Right, exactly. So
what about things that prolong the QT interval?
Pass.
I mean the QT interval. Yes,
yeah, probably. Yeah, something to do with the heart, isn't it?
Yeah. I kept a bit lost. Yeah, no, look, there we go. Significant QTC prolongation, unless
prolongation.
Yeah.
So yes, there you go. That would appear to be a problem as well. And I think that's not a big issue, because doing ECGs is easy. And as I have said to you before, when we were junior doctors, we used to admit people to give them ACE inhibitor, their first dose of ACE inhibitors. And I think we'll get around that. I think, I don't think the side effect profile is particularly troublesome. It's about when it gets to be a pain and a difficulty to start using it. And I think an ECG is easy. Fundoscopy by someone who can actually see the back of the eye is a little bit harder. And I think
that's only in a subgroup, isn't it?
It is only in a subgroup. So, but it's gonna, if all things are equal, you're gonna take the path of least resistance, aren't you?
Yeah.
So a couple of other things. You say first in class, but of course it's not first in class outside UC.
No, there's fingolimod, which is out there for multiple sclerosis.
And when you're thinking about trafficking of lymphocytes to the brain, does that concern you?
Well, I'm worried, of course.
It's almost a loaded question.
It is, because you're worried then you're talking about, is there a risk of progressive multifocal leukoencephalopathy, which has been reported in patients treated with fingolimod. But it's also, there is a single case in the ozanimod clinical trial program. So a single case of PML. It occurred outside of these trials, so it's not reported in the clinical trial data. And of course, it's pivotally, critically important to know as much detail about that case as possible.
And then, or to play devil's advocate, maybe it's not, because it's one patient out of X 1,000 patient years, and we've just said that we're quite happy using tofacitinib when we've seen a trial that clearly shows significant side effects associated. And
so I guess we need to know more about that case, and I don't know enough about it yet.
No, indeed. You want to move on?
I think so.
Okay, all right. That's what that sign means. Let's just see if anyone has raised. Oh, there's a couple of things here. So, Paul, is that related to?
Yeah, no, Phil. Nice. September 22 is the nice TA date for filgotinib.
Right. And he's saying, is anyone going to use it for that? I don't know.
I don't know about a compassionate use program.
Yeah, neither do I. Paul Harrow again, the ECG and eye assessment is a little inconvenient. Agreed. This will be a barrier to me using it.
Yeah.
Well, ECG, I think you can cope with an ECG, Paul. Surely. I agree. The eye assessment is, I mean, let's face it. If we can do a chest X-ray, TB IGRA, Hep B, C,
we can do it.
HIV, we can do it in ECG.
And then another great point from Razor here. You're right. People with maybe it's second and third degree block will have a pacemaker. And of course, if you've got a pacemaker in, you can give us Zoonamod. That's not a problem.
Yeah, good. Okay, I've forgotten what we're moving on to next. Oh, Seaview. Seaview, I think was a great study. It was, of course, the first head-to-head biologic study in Crohn's disease, and it took a group of patients who were effectively naive to biologics. They could have been on thiopurines, but they had to stop them. Standard moderate to severe Crohn's 220 to 450, and then randomize them to either adalimumab or ustekinumab. Let's talk about the dosing first, because that's always a little bit controversial in these studies. Dosing of adalimumab was standard induction 160/80 and then 40 milligrams every other week as per the US label, with no escalation of dose. And ustekinumab was also by the US label, and by that what we effectively mean is that everyone went on to Q8. So you might argue there's a bit of a difference there. It was designed as a superiority study. It was powered for ustekinumab to be superior to adalimumab. So we need to bear that in mind. And the primary endpoint was clinical remission at week 52. And you can see the primary endpoint at the bottom left there. 61% of patients treated with adalimumab were in clinical remission at week 52, compared with 65% of patients with ustekinumab. But it missed its primary endpoint.
By a long way.
Not by a huge way, but
it didn't show superiority.
It definitely didn't show superiority. Yeah. But what we can't say is anything about equivalence, because it wasn't powered that way.
It wasn't powered for equivalence. Yeah.
But I'm going to ask you a question here. Even though we can't say anything about equivalence, do you think they're equivalent?
Well, statistically, you can't say that, but they look pretty similar to me.
They do. All right. So there's a couple of other big things that come out of this for me. The first is the remission rates at week 52. I mean, it's stunning, aren't they? 60 to 65% of patients, and nearly all of those were in steroid-free remission.
Of course, this is not a placebo-controlled trial. So you don't have a placebo comparator. But if we compare across other well-designed, nicely executed trials, those remission rates are really impressive. So how does the patient population differ from that is recruited to the sort of trials that we see a 30, 40% rate? And of course, there's another thing, of course, because these aren't randomized responders. This is a treat-through trial,
right?
Isn't it?
Right.
So it's not that you only select the responders to induction to take through to maintenance. This trial takes everyone. This is all comers. So why are the patients different?
Well, they are, yes. I mean, they're definitely treatment naive. Okay, so that's really important. They're biologic naive patients. They have a short disease duration, but I think perhaps the biggest telling point is that the SCSCD, so the endoscopic activity of their Crohn's disease, I think the median levels about, average levels about 8 or 9, something like that. If you compare that with your standard sort of moderate to severe population trials, they're sitting more like 12, 13. So they were a less severe population. But to me, that says, my God, these are the people we should be treating with biologics.
Yeah, I mean, so I guess, I mean, they're a less severe population, but there are not people with minimal disease.
They've not got IBS. They've got active Crohn's disease, haven't they? So that was good. The other thing that I really liked about this was there was robust endoscopic data.
Yep.
I'm not sure, did we show that on the next slide or not? Yes, we do. Let's go. We'll come back to that, the previous slide, because I just want to highlight a couple of things on there. But you'll see there was a change in the SCSCD score. I'm not sure why we haven't got the 50% improvement there, which is probably the sort of the most commonly used endpoint when you're thinking about SCSCD. But if you look at these endpoints, you see at least equivalence You know, there's some numerical advantages in these secondary endpoints. Of course, they're hierarchical endpoints. So because the trial missed its primary outcome, then you can't, all the p-values after that are nominal. Nevertheless, you know, there was some suggestion that there was a marginal benefit of ustekinumab over adalimumab. I don't think it's going to be hugely clinically significant, but to me, it says we know that anti-TNF is a good mechanism of action in Crohn's disease, and we know it heals the mucosa, and so does ustekinumab.
I guess what would be interesting would be to know how these response remission rates correlate with drug exposure, i.e. can you get better if you escalate the dose of one, if not both drugs?
Right, and also importantly, you know, because you need to think about persistence, don't you? And this is something that CView wasn't set up to do. You know, it was a treat for 12 months, and then you do whatever you want after that. And that's sort of one of the problems with double dummy trials. You don't know which drug your patient is on, okay? So you don't know which one to continue, so you can't get the long-term outcomes, can you? You know, you'd expect more immunogenicity, wouldn't you, with adalimumab in the long term, particularly when they are not exposed to azathioprine. And you know, there was a hint that the patients on ustekinumab were more likely to be on drug at the end of 12 months rather than the adalimumab patients. There will be some immunogenicity data coming out probably at UEGW, so we'll get some idea then.
And I think Charlie raises exactly that point here, which is a really nice point, is it'd be super interesting to see outcomes at 2 and 3 years. You would think that ustekinumab might be better in the long term because there would be lower anti-drug antibody formation, although he points out that adalimumab looks good. And I think that's great. But of course, the trouble is, as you say, at the end of the trial, you won't necessarily know which drug to continue your patient on.
No, of course, you could cheat. You could just measure an adalimumab drug level at the end of the study, couldn't you?
Yes.
And then you'd know which drug they were on. I don't know. It's something that we could raise with Janssen. And that is, of the patients who complete CView, some of them will have continued on the drug they were on in CView. Whether they can get some longer term data there, I don't know. It's going to be pretty weak though, isn't it? If we're honest about it.
Paul raises a really nice question about the use of biosimilar P40s. I don't know how far we are away from biosimilar P40s.
All right, well, let's not that far at all, because it comes off license earlier than you think.
Oh, 2023, Paul's just
right,
me.
exactly. So it varies in different parts of the world, I'm sure. I'm not sure they'll be flooding America quickly, but again, Paul might update us there, knowing him. But all right, I'm going to spin that question back at you then, James. All things being equal, if you had a patient now with moderate to severe Crohn's disease, first biologic, what are you going to use? You can use whatever you want.
So if cost were not an issue.
It's not. I'm giving it to you for free.
I mean, obviously from this data, you'd say either adalimumab or ustekinumab would be great choices. Ustekinumab, to my mind, would have it because of the more favourable safety profile and my perception that it's less immunogenic, which, I mean, it is less immunogenic.
Well, it is, yeah.
The question is whether it becomes less immunogenic in this study.
Yeah, and, you know, I guess lack of need for azathioprine, which really feeds into that, doesn't it? Yeah, so Paul, yeah, I think you know it's a critical question, and I'm sure it will influence prescribing in the medium term.
So we're going to move on to a related concept, which is sequencing in ulcerative colitis. This is a slightly difficult study to present, but I'm going to do my best. It comes from Australia. It's a retrospective claims database, a pharmacy claims database, looking at persistence on drug. And having done a little bit of back reading into this story, the data that I'm about to present actually comes from a much larger series of patients that have just been published in Alimentary Pharmacology and Therapeutics. So I'm going to tell you about the mother paper, and then we'll get on to the detail here. The mother paper looked at 2,500 patients with inflammatory bowel disease in Australia over just over 8,000 years. And effectively, it used a pharmacy claims database to assess persistence on therapy in both Crohn's and ulcerative colitis. And what it showed was that at 1 year, the persistence on therapy in Crohn's disease was 80% for ustekinumab, 73% for vedolizumab, 68% for infliximab, and 64% for adalimumab. Now, clearly, you don't know why they were persisting on therapy or why they were dropping off therapy, but those are the data. And therefore, there was a hazards ratio of remaining on ustekinumab versus anti-TNF of 1.79 in Crohn's disease. So in answer to your question, therefore, I should have put you on ustekinumab, which is what I said.
You're doing well.
Yeah.
You should think about doing it for a career.
In ulcerative colitis, the Ersti wasn't included because it wasn't available in Australia at the time. The persistence at 1 year on vedolizumab was 73%, on infliximab was 61%, and on adalimumab was a lowly 45%, with a hazards ratio of persisting on vedolizumab versus all anti-TNFs of 1.67. Interestingly, in this large study, immunomodulator increased persistence in anti-TNF treated patients with UC and Crohn's disease, but not in ustekinumab or vedolizumab patients. And first-line therapy was always superior, irrespective of drug, to non-first-line therapy in terms of persistence. So having said that, let's look at this study in front of us here, which is looking at vedolizumab or anti-TNF first line in patients with ulcerative colitis, and then secondly, the efficacy of second line, either switching anti-TNF to vedolizumab or vedolizumab to anti-TNF. And this was a smaller subset of that 2,500 patients, just over 570 patients, of whom first line, the majority, as one might expect, were treated with anti-TNF at 400 and 169 with vedolizumab, just under 1,000 years patient follow-up. When you look at the patients who switched, 65 patients switched. So as this is now becoming very small numbers. That figure's not quite right, because it was 65 TNF to vedolizumab and 31 vedolizumab to TNF. So it was 96 patients switched. Now, if we look at the difference between the patients who started first-line anti-TNF or first-line vedolizumab, those who started first-line anti-TNF were younger, and that might be as you expect, because people tend to use vedolizumab in the older patients. If you then look at persistence, 69% who started first-line vedolizumab continued on first-line vedolizumab, compared to 52% who started on first-line anti-TNF, and that's shown here. So this is first-line treatment with vedolizumab in red, first-line treatment with anti-TNF in blue, showing persistence over time, and this is a significant difference. Then if you look at the other way, second line, so don't forget now the numbers are becoming very much smaller, 63% of people who switched from vedolizumab to anti-TNF, no, sorry, other way around, 63% of patients who switched from anti-TNF to vedolizumab persisted on it, compared to 83% of patients who switched from vedolizumab to anti-TNF. So the exact reverse. Persistence better with vedolizumab as first-line therapy, persistence better with anti-TNF as second-line therapy, although fair to say, this second analysis with the small numbers was not statistically significant. Factors that predicted non-response, or the other way around, factors that were associated with good response were being male, having first-line vedolizumab use, or immunomodulator co-therapy if you are on an anti-TNF. Now, the sequencing aspect of this would suggest we should be using vedolizumab first line in ulcerative colitis, and of course that fits with the VARSITY trial. I always have a slight hesitancy in this kind of data, because of course it's claims database. It doesn't tell you anything about what was happening to these patients' disease. It doesn't tell you anything about why they switched. It just tells you that people persisted on a drug longer. It might have been glorious inactivity from their physician.
Right. I mean, you know, there are so many ways that you can suggest confounders here, aren't there? So I'm going to say, if I put a patient on vedolizumab first line, then it's because I'm worried about using an anti-TNF, and I'm not using. But Australia's a very cost-sensitive market.
Yeah.
A very cost-sensitive market. So in that case, you're reluctant to take them off the vedolizumab and put them on the anti-TNF. So therefore, persistence is better.
Yeah, absolutely. And that could be the explanation for this. Marcus asks a really nice question here. Why is infliximab better than adalimumab in the mother paper? That was the original paper I described with the 2,500 patients. He says it's counterintuitive. And it sort of is, because you might expect that infliximab being more immunogenic than adalimumab would have lower persistence. And I guess it might reflect the fact that adalimumab is underdosed compared to infliximab. And the ability to dose optimize might be lower in Australia. I don't know the answer to that. And of course, Marcus, this is exactly the problem with this kind of data, is you don't really know why anything was done. You just know what was done. And it's interesting, but perhaps shouldn't be driving practice.
Yeah, and I think
that's a great comment there from Charlie. Drug persistence is a lousy surrogate for drug effectiveness. And I completely agree, because persistence can reflect excellence of drug efficacy or awfulness of medical care. So it's very difficult to know.
Right. And, I always think back to Tarek talking about some of the PANTS patients who, after a year of treatment on anti-TNF, had zero drug levels for long periods of time and high CRPs and high HBIs and were still on infliximab.
Yeah. And,
so
I think that's also a lesson. I think let's move on. We've probably done that sequencing a bit.
What it needs, though, as we move on, is a decent trial.
Yeah.
I mean, that's that.
Well, there is a trial. There's Varsity.
No, that's not a sequencing trial.
Ah, sorry, a sequencing trial. Yes, we need a decent sequencing trial. Hard to do.
Yeah, but might as well do it. Okay, you're making me work again, aren't you? How do I get rid of that? I press that button. No, not the red one. Okay, so this is a great study. DDW is littered with variable quality studies, but this one is one of the good ones. And this one isn't a drug company study, it is an investigator-led study. And it really takes us back to Story, Edouard Louis' study of looking at patients who are on combination of infliximab and azathioprine for Crohn's disease, who then discontinued the infliximab and looked at their outcome. And basically, the long and short of it is about half of people relapsed over time. And indeed, Edouard subsequently got a massive European grant that has allowed the Biocycle and Spare program to be undertaken, which looks at those patients who are on combination therapy with infliximab and azathioprine who are randomized either to continue infliximab or continue azathioprine, and then critically also looks at how the response to loss of response in those situations varies across the three different groups. Of course, the trouble with Story was that there was no control arm, and here we have a study in which there was a control arm. So this is 115 patients who'd been on infliximab for a median of 24 months or so, who are randomized either to continue their infliximab or discontinue it. Interestingly, they didn't have to be on azathioprine as well. So some of these patients with Crohn's disease, when they stopped the infliximab, were on nothing at all, which I think is quite
feisty.
Yeah, it was quite feisty, really, wasn't it? Nevertheless, that's what they did. And it looked at a year outcome to see how many patients remained in remission. And so look at the graph over on the left-hand side here. The black solid line at the top there are the patients who continued infliximab, and you can see they did rather well. None of them relapsed. Whereas,
but of course, these was a group of patients who were doing well on infliximab, wasn't it?
Yeah, but you wouldn't expect 100% of patients to remain in remission over a year. I mean, it's about 60 on in each group, so fair enough. But still, I guess you're right. It tells us what we know, that if people are doing well on infliximab, continue to do well on infliximab. Whereas if you stop the infliximab, about half of them have relapsed by the end of the year. So if you look at the grey line in the middle here, that's all comers who stop infliximab. The green dotted line is those patients who happen to be on azathioprine as well, and the blue or whatever it is dotted line are the patients who weren't on immunosuppressants, so they go on to nothing. So it shows you, well, it shows you there's a marginal benefit of being on azathioprine. There is a benefit, but interestingly, spin this another way. 50% of patients who've been on infliximab for 2 years, if you stop the infliximab, they're absolutely fine after a year.
But that's that half glass full, half glass empty argument of infliximab.
It is, and of course you don't know where that graph goes after that. Although, interestingly, the big loss of response is early, isn't it?
Yeah, I mean, and I wonder whether, and of course this trial didn't look at this, but if you were to have done calprotectins in these patients, could you predict those who are losing response, restart them and recapture them? And of course, you know, that's sort of what we do in clinical practice for those we stop. And of course, we just don't know the answer.
As was seen in Story.
As was seen in Story.
Right. So there you could see the calprotectin go up. So how were patients followed? They were followed clinically. I can't remember what the time points were for review.
How frequently they were reviewed? Yeah, because the endpoint was relapse symptom-wise, and it was a symptomatic endpoint for relapse. I don't remember how frequently. That was Anna, one of our nurses. How frequently they were assessed.
Yeah, but I mean, I might try and look that up just as we go on to the next study, because we've got 20 minutes left and we've got two other topics we wanted to look at, haven't we?
So I think, so we've done sort of sequencing, stopping biologics. I'm going to just do one of the new biologics, and this is risankizumab. This is a combination of two trials, the induction trials of risankizumab, which is an anti-P19. So it just impacts IL-23 signaling, unlike ustekinumab, which impacts IL-12 and IL-23. Risankizumab just impacts IL-23. The reason we think we're interested in this as a drug is that in psoriasis, when there have been head-to-head trials of ustekinumab versus risankizumab, risankizumab has shown superiority in several different objective and subjective measures of improvement in psoriasis. So this, though, is not a head-to-head trial. This is a placebo-controlled phase 3 induction trial of standard group of patients with moderate to severely active Crohn's disease, and they either in one of the trials had previous exposure to biologics or were biologic naive, and in the other trial were all biologic exposed. They were randomized to either placebo or one of two doses, as chosen in the phase 2b trial of 600 and 1200 milligrams of risankizumab versus the placebo. And you can see here a remission on the left, response in terms of endoscopic response on the right, and a really nice signal of benefit for this P19, delta above placebo upwards of 20%, clear evidence of efficacy, actually interestingly with no particular dose benefit. So the 600 milligram dose is the dose moving forward. There's data presented at ECHO that shows quite early onset of clinical improvement, certainly by week 4, which was the earliest point that it was collected. And I think, you know, what we can see here is a new drug with obvious benefit. The gazelkamab trials, which was another P19, did actually have ustekinumab as a comparator and didn't seem to show a significant benefit of gazelkamab above ustekinumab, but they weren't powered to show that. The sequence trial, which is currently running at the moment, is a head-to-head ustekinumab risankizumab trial. It's only just started, but I think it will be really interesting to see the outcome of that trial.
I think if I was a patient with Crohn's disease, I wouldn't mind going to sequence.
No, I think sequence is a great trial.
I think it is. I think it's a good trial. So I'm going to ask you a question then, James. Is P19 better than P40, anti-P19 better than anti-P40 in inflammatory bowel disease?
Well, we've got absolutely no evidence in inflammatory bowel disease suggested it is.
I know, but I'm asking you to speculate.
So why might it be? Well, it might be because the P40 pathway, if you interrupt that, you interrupt signaling through both IL-12 and IL-23. And there is some evidence that IL-12 is important in some regulatory responses within the intestinal mucosa. There's a trial, it's only in mice, and it's looking at a weird infection, showing that actually IL-12 was important in preventing too much inflammation associated with this infection. Actually acts really interestingly centrally on the bone marrow rather than peripherally. So there is a theoretical reason why purely targeting IL-23 might have benefit. And obviously that has been seen in psoriasis. I'm going to be cautious about speculating beyond that until we see the results ahead.
But you believe that P19 is a good mechanism of action?
I definitely believe it's a good mechanism of action.
How many patients have you treated with risankizumab in trials?
It's a good question. I would think upwards of 10 or 12 patients in our trial program.
Okay, and basically, by the time you've gone through a certain amount of time, all these patients end up on drug.
They're all doing fine.
Right. And I think you do get a feel, don't you? You know, we've treated. I remember the very first patient I treated in the phase 2 before it was risankizumab, and it was a patient who'd failed both adalimumab and infliximab, which were the only drugs available then, and went on to P19, and it was.
Yeah,
I think it's a good mechanism of action.
Miles Parks here raises a really good point, which of course is that if you were to, again, it's about this plausible hypothesis. I've given a very roundabout plausible reason why P19 might be better than P23 looking at mouse models. Miles has actually hit the nail on the head, which is saying that, yeah, if you look at genetic susceptibility, it's patients with issues with IL-23 signaling that have a protection against the development of inflammatory bowel disease. And so there is a clear genetic signal about why focusing on IL-23 might be relevant for Crohn's. Thanks, Miles.
Of course, the history of immunology explanations and genetic explanations is such that you can probably argue what you want, really. But
that's a good argument. I think with that, we'll move on to our last abstract so that everyone can get on and enjoy their evening. And that is Pete's.
Right, and I'm going to caveat this by saying it's a terrible abstract.
It's a
terrible abstract, but it's actually it was something we wanted to discuss because, I think we believe that if we are to make major advances, despite these new treatments that we've been highlighting, if we are to make major advances in inflammatory bowel disease, in terms of breaking through that ceiling of steroid-free remission, then we need to be doing something different. And the thing that we haven't really done in IBD, perhaps with the exception of anti-TNF and azathioprine, is combine different mechanisms of action. And yet, if you look to oncology,
do it all the time.
They do it all the time, and very effectively as well. Look at even with new drugs, look at the checkpoint inhibitors that have come into our lives.
Oh yeah.
Right. They started putting them together very quickly. Anyway, so this is a systematic review of patients who have combined biologics and or small molecules in inflammatory bowel disease. And it includes one randomized controlled study, which is sort of probably the least relevant combination to us, that is natalizumab and anti-TNF, because of course we don't use natalizumab. And the rest are all a series of little case reports and things. And I think what they say, and I really wouldn't try and draw any more out of this at all, is that you can give these drugs together without causing too much toxicity. I think, if you look at the papers that are starting to come out, then people are trying to interpret these as suggesting there may be some combinations that are better than others. And this is where I actually have to go back and take back completely what I said about genetics and immunology, because in fact, I think we should be using genetics and immunology to help guide us here, as well as safety, critically.
I think there's been a real barrier in the IBD community for combination therapies. and I think there are two drivers for that. One driver is cost. Cost is limiting. It's challenging to do because the combining biologics is really expensive. And the other, and I think that's a very real barrier, the other is a safety barrier. And I would argue that's a less real barrier. Because of course, as you said, we use combination therapy all the time. We use steroids with biologics. We use steroids with azathioprine. We use steroids, azathioprine sometimes, and biologics, and we give people Septrin just in case they get PCP. And yet we're worried about combining two very targeted drugs that have very favorable safety profiles compared to, for example, steroids and azathioprine. So I really think we should be looking at combinations. And to my mind, I sort of favor the concept of a get you better combo followed by a keep you better combo. And within the get you better combo, you're prepared to accept a higher risk for a higher return, whereas in the keep you better, you need to keep your safety there. And for me, I think that's where combining small molecules and biologics will have a real advantage, because you can use the small molecules episodically without a risk of immunogenicity. And therefore, you know, for me, it's a JAK inhibitor and either ustekinumab or vedolizumab. That's where my combo comes.
What would you think? So I got an email today, James, that it was from someone from a different specialty that said, this mutual patient of ours, the specialty was another, an IMID type specialty. This mutual patient of ours has just developed COVID. I've stopped their MMF and their tofacitinib, but they're on high dose steroids, and I'm a bit worried their UC might flare.
yeah, I'd be a bit scared about tofa and MMF, I have to say.
Right.
Their impact on lymphocyte function would be pretty dramatic. Knockout, I'd be pretty scared.
Probably works quite well.
Yeah. I mean, of course, you know, this is exactly where the clinical trials of the future are heading, and this is exactly where we need to be heading. I do think at the moment, use of combo biologics is difficult because of cost, but obviously combining a small molecule with an anti-TNF is not actually that expensive at the moment. Marcus says a really good question here about the washout times between different biologics. And I guess, actually, Marcus, that's a very pertinent question, because I think the very fact that I'm very happy to just start the next biologic without a wash-up period means that I'm happy with combo therapy from a safety perspective right from the beginning. And as I said, I think the issue with combo therapy with advanced molecules and biologics is not really safety, it's cost. And we need to get cost to a level that is acceptable to our payers.
Well, I mean, that's interesting, isn't it? So, I mean, I completely agree. So, Marcus, I don't wash out at all, whatever. Just move on to the next one, because let's face it, like you said, we've been poisoning people with combinations of drugs for long periods of time. We actually have provisional agreement from our CCG to use combinations of biologics in certain groups of patients based on the fact that biosimilars are cheap.
Yeah.
And, you know, and so what we haven't proposed is using vedolizumab and ustekinumab together, because that's a bit chunky. But yeah, no, we do have provisional agreement for some anti-TNF and other biologics.
And I'm sure that's, I mean, that either the combination of drugs or that choosing the right patient for a drug, because if you can select patients with super high response rates, then that's the way forward.